Well, my next guest is an orthopedic surgeon. Dr. Charles Gatt is the chairman of orthopedic surgery at the Rutgers Robert Wood Johnson Medical School and at the Robert Wood Johnson University Hospital. He's with the University Orthopedic Associates in New Brunswick, New Jersey. Dr. Gatt, are you there?
Yes. Hi.
Thanks so much for taking time. It's a real pleasure talking to you tonight, and thanks so much. I see you in the locker room all the time, but we haven't had a chance to have many discussions. But tonight we're going to talk about ACL repair. So whether you're a young athlete or one of us older weekend warriors or even someone working out in the garden on the weekend, you're going to be interested in this topic, knee injuries, particularly these anterior cruciate ligament injuries. They're very common. They can sideline even the most active athletes. So we've got Dr. Charles Gatt on the phone, and Dr. Gatt is an orthopedic surgeon. So I want you to tell me, what is an ACL?
Okay. So the ACL is the anterior cruciate ligament. It's one of the main ligaments in the knee. And ligaments are like ropes, and so what they do is they control the position of one bone in relation to another. So for the primary job of the ACL is to prevent your shin bone or your tibia from sliding forward from underneath your thigh bone or your femur. It's a little bit of sliding. It prevents sliding forward, but also controls rotation. So it's really the main stabilizer of the knee for twisting and pivoting activities, like if you play basketball or soccer or football or dance or anything like that, where there involves a lot of rotation around the knee.
But it's injured so often, it seems that almost everybody seems to have these knee injuries, and they need you to repair them. What causes the torn ACL?
Well, it's usually a sudden change in direction that's unexpected. So, for instance, if a soccer player is running down the field and thinks they're going to have to go to the left, and suddenly they have to change direction real quickly and go to the right, that they'll have a quick twist to their knee, and that's usually what causes the injury. You can see it in hyperextension injuries when skiers go over the tops of their skis. A lot of people think of ACL tears as being caused by contact. In other words, like when a football player dives into another player's knee, and that happens. But the majority of the injuries are actually non-contact, twisting-type injuries.
All right. So let's say that someone has a torn ACL. Well, first of all, how are they going to know it was torn? I mean, is it just pain, or is there a particular symptom?
Oh, well, the classic symptom is a pop. So, typically when I see athletes in my office, they come into the office, they're on crutches already because of the pain. But I say, well, what happened? And they say exactly what I just described. They say, out on the field, and I was running down the field, and I had to make a quick twist, and I felt a pop in my knee, and I fell to the ground. And that pop is the classic symptom that they describe. And as soon as they fall to the ground, they try to get back up, and their knee feels unstable to them. It feels as if it's going to give out, and they almost can never continue play. They're usually out of the game. And luckily, athletic trainers at high schools and at the college level are very well trained, and they pretty much can even make the diagnosis on the sidelines as well. But it's a very classic story. Usually by history alone, you can almost make the diagnosis.
My guest this evening is Dr. Charles Gatt. He is the chairman of orthopedic surgery at Rutgers Robert Wood Johnson Medical School and at the Robert Wood Johnson University Hospital in New Brunswick, New Jersey. Now an expanding hospital all over the state. There's a big merger. We'll talk about that next week on this show. All right, so let's say someone has this injury, and now they're on crutches. They've got all this pain. They heard the pop. What do they do next? Who do they see?
Well, I think it's important to see a physician that specializes in sports medicine, and even in orthopedic surgery, we have our own subspecialties. I specialize in sports medicine. There are primary care physicians who specialize in sports medicine, but especially if you're a young, active, athletic individual, most likely this injury is going to, you're going to have to consider surgery as an option. So your best bet is to see an orthopedic surgeon who specializes in sports medicine.
Okay, so now the person, whether it's a teenager or one of these skiers or someone like me in the garden on the weekend, has now seen you. I've got pain. I heard that pop. What do you do first? What do you do for me?
Okay, so when you come to the office, I ask you to describe how you injured your knee. And again, a lot of the times by history alone, I can pretty much hone in on the diagnosis of ACL tear. Next, I would do a physical examination of the knee. The knee is usually swollen. There's limited range of motion. but by trying to move the tibia forward, I can feel that the tibia moves more than, or the shin bone, I should say, so everyone understands it, normally moves forward further than it normally should. So by examination, I can almost always make the diagnosis by physical examination. We'll take an X-ray just to make sure that there's been no fracture associated with the injury. It's relatively uncommon, but it's possible. Then the next step is usually to get an MRI of the knee. And the reason we get an MRI is making the diagnosis of ACL tear on history and physical examination is relatively easy, to tell you the truth. But there are other associated injuries, and up to half the time there can be damage to the meniscus, which is what people commonly refer to as torn cartilage. But the meniscus is the rubbery shock absorber that fits between the bones of the knee, and the tears of the meniscus have consequences in terms of how we make a decision how to treat the injury, and also damage to the cartilage, which is the shiny covering on the ends of the bone. So the MRI helps us make that diagnosis, which is much more difficult to make than without the MRI. We can't really do that very well without on physical examination alone.
Okay, so now we've gone to you. I've gone to you. I'm in my crutch. I've got a splint on because it hurts so much, and you tell me maybe I need surgery. Is there any way to avoid surgery with this injury?
Sure, there is. If you're, you can go to physical therapy, strengthen your thigh muscles, your quadriceps, and your hamstrings, and work on some balance training. The technical term for it is called proprioceptive training. But you can, kind of stabilize your knee with physical therapy, and generally decrease the instability to an extent. I think what it really comes down to is what your activity level is. For instance, if you're a Division I college athlete, and you ask me what are the chances I can play Division I college soccer without surgery, the chances are probably less than 15%. If you're a 60-year-old skier who skis blue squares and doesn't bounce off the moguls, and you tear your ACL, odds are the chances of you needing surgery to return to your previous lifestyle is probably only about 15%. So again, the tables are completely turned. It's the middle people that are the ones that we have to decide. And again, we really base that on their activity level, their desire to return to sports, how important that is, as a part of it. I see so many, women who, like for these soccer leagues, are such a major part of their life. It's something that they have to do. And, the likelihood of them playing that level without having surgery is not particularly high, to tell you the truth. So a lot of factors come into it, but activity level is definitely a main component of the equation.
Okay, so I'm 59. I've decided I still want to try and compete in the Olympics, so I'm going to have the surgery. What are you going to do for me? What kind of surgery is available?
All right, so the surgery is called an ACL reconstruction. A long time ago, they used to try to sew the ACL back together. That didn't work at all. So now our techniques have really, have been perfected to the point where the outcomes of surgery are very good. What we do is we reconstruct. It's an ACL reconstruction. So we use other tissue to rebuild the ACL. Now, in a person, like you said, if you're 59 years old and you want to go out for the Olympics, you probably would do very well with allograft tissue or donor tissue. That works really well. If you're a high school or college athlete and you say, look, I need to get back and play soccer or basketball, then we use your own tissue. And the two most common choices are a small portion of the patellar tendon, the big tendon that goes from the kneecap down to the shin bone, or two of the hamstring tendons. Everybody thinks of them in the back of the knee, but they actually attach to the front of the shin bone, and with a small incision, I can take those tendons out. There are other tendons that compensate for them when they're gone. And we route those through the knee arthroscopically, so it's done with very small incisions. We drill tunnels into the bone and put the tendon graft into the tunnels where the old ACL used to be. It grows into the body and becomes a new ACL. And the outcomes of surgery are excellent. People, there's a 90 to 95% good to excellent result. People return to their previous level of sports. Very high satisfaction. It's a great operation.
And that is a great summary, and I really want to thank you for being my guest this evening, Dr. Charles Gatt, Chairman of the Orthopedic Surgery Department at Rutgers Robert Wood Johnson Medical School and the University Hospital. Dr. Gatt, thanks so much. It's been wonderful speaking to you. I hope I never need your services on my knee. Thanks. Have a great evening.
You too. Have a nice night. Thank you very much for having me. Bye.
Okay.